growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner here with another episode of The Lionhearted. Keeping in line with what I said last episode, I've kind of shortened these a little bit for you because I think it makes it more user-friendly. You can feel free to write to me and correct me if you don't agree. Doing my best over here. So welcome to The Lionhearted. As I also stated, I'm going to try to go, 75% management, helping you manage the best road possible to maximize your success in the profession of dentistry that we both have chosen. Anyway, let's get right into it. Last podcast, I was talking about the skill sets, what I take. I mean, it's overwhelming. First of all, it's expensive, especially for the newer dentist. You can't just take anything and everything you want. So what would be the biggest return on my buck if it was me? And, ad nauseum, I've reminded you that what I would advocate is focusing my skill sets on oral sedation, atraumatic extractions, site development, and of course then surgical implant dentistry. I actually keep calling it the triad, so I should rename it because we're really talking about 4 separate skills. And the first, and today I want to give you the why. Again, I want to remind you, and the reason I'm doing this, even though I know I've done it before, is because I know personally sometimes I need to take things or hear them multiple times for them to have an impact on my behavior or what I'm actually going to do. So why else would I tell you this, except that I really believe in my heart that it is the easiest path for you to have 2 things. A successful career, if you judge that financially, and 2, by the interest level that it maintains on a weekly basis on what you get to do. So let's review it real quick and let me elucidate. I've done a couple podcasts just strictly dedicated to oral sedation. So I don't want to go over too much of that detail again. Again, you can write to me at drrasner@aol.com, and I would invite you to do that. And will be sent on your way is a full protocol of what I use. If you're tuning in for one of the first times, I doubt many of you, if any of you, have used the combination I use of triazolam, Atarax, and Benadryl. And I'll give you the details if you write to me as to how, or look at my earlier podcast as to how do I use those. And just in case I haven't made it clear in the back podcast, you do need, in my opinion, let's talk about this for a minute, to combine it with nitrous oxide. You see, because the pills put the patient at a certain level, and nitrous oxide enables you to take them a little deeper or make them a little more shallow in their conscious sedation, whatever you feel the need based on their behavior, based on what you're seeing with your own eyes. And so let's talk about that, because I come across this a lot, because when I teach on the road, lots of you are not in private dentistry. You may work in public health dentistry, and you may not have access to everything I'm talking about. And then the second thing is, well, what about the requirements? In most of the states I have lectured in, I have found that you can use one of the 3 I just said, one of either Benadryl, Atarax, or triazolam, and along with one other component like nitrous. So naturally, if I was in one of those states, and in the meantime of acquiring my sedation permit, which you've heard me talk about every podcast that addresses this subject, you need to simply, a lot of you write to me and say, what course should I take to qualify me for the oral sedation permit. And it's totally up to your state. It's got nothing to do with the courses out there. I'm getting ready next week to take 20 hours spread over a few days to renew my sedation permit in the state of New Jersey. In most states, what you'll find is a requirement, I believe, of somewhere between 40 to 60 hours for the initial permit, and then 20 every 2 years just to renew it. Now, there are some states, for sure, where they will require you to get an IV permit, which obviously is much more extensive, even though your intention is just to dispense the pills I alluded to. Even though you have no intention of performing IV sedation, in some states they will make you take that. So I would say this to you. Yes, if you just gave them 0.25 triazolam along with nitrous oxide, that will give you some sense, some level of sedation. It won't be as profound as if you get Benadryl and Atarax, but it will put them in a state of internal sedation. And yes, I would encourage you to do that. I have done both, and I will tell you that, to me, the ultimate cocktail are the 3 drugs I alluded to, along with nitrous oxide. But I'm reiterating, if you're allowed to just give triazolam and nitrous, then do so. Next step. So again, I've told you way too many times on these podcasts why that's such a great skill to acquire. And by the way, you've also heard me say, and if you really think about it, it's not that big of a skill. It's more of acquiring a permit. So you've proven to some body of government that you have a background in this of information, and you are qualified to recommend and dispense these pills that I'm alluding to. So why? So it's not even a skill. Meaning that the first time you give that combination of drugs, you're equal to my ability to give that combination of drugs. So there's not too many things on the planet like that. But naturally, you have to take the responsibility very seriously and be prepared for what's coming your way. And here's the deal. Even though I've done many podcasts on this, even though that I've done this all over the United States and abroad, very few of the audience actually moves the idea that you're hearing right now into action. Very few people will get up tomorrow on Monday and have somebody call their board of dentistry and find out what courses you need to take. Because they'll give you a broad spectrum of courses that they approve. That's what's going to happen. Some of them let you take the DOCS, the DOCS, which I know is very, very popular. My recommendations are different than the DOCS, but it doesn't mean it's not a good program. It's just not what I use. I have tried that program. I prefer mine. But very few of you will do that. So what that does is it puts you in this position to market what you do. And I am telling you, and you've heard me say this, I always say it this way, pardon the redundancy. I don't own a red Corvette, but if I did own a red Corvette, I'm told that you see a lot of other Corvettes all of a sudden on the road. I'm here to tell you that when you market sedation in your community, no matter where you are right now listening, over the course of the next 12 months, you're going to have a number of patients, surprising number of patients, that come to you because you perform what they call sleep dentistry. It's an amazing market. Now, that sets you up for the next 2 skills. And the next 2 skills are atraumatic extractions, because although I don't expect all of you to get it right now, you're going to be shocked at some of the people that you meet. You're going to meet people from ages 16 to 80. And some of those people have not gone to a dentist in 10 or 20 years because of an incident earlier in their life where they were hurt. I'm not kidding. That's how powerful, long-lasting the impact of a negative dental experience can have. I can tell you firsthand from talking to these patients about it. And so you'll have somebody come in and it'll be stunning to you. And they're going to need multiple extractions in many cases. And so it wouldn't be congruent for you to advertise that you do sleep dentistry or provide oral sedation and then send them over to the oral surgeon. So excluding wisdom teeth, that's a subject for another day. I do refer my wisdom teeth to my oral surgeon for no better reason than there's a lot of variation in the anatomy between lower, second, and third molars. I can take out third molars, and I do sometimes, but I don't base my practice anywhere around that, nor would I recommend it for most GPs. It's just not a big ROI, return on value, service that you provide. But you're going to get a number of people that are going to have, there might be a Bruxer patient with really thick bone and have teeth that have broken off to the gingival margin, and you need to get those teeth out. So naturally, I'm going to recommend to you that then you must be skillful in atraumatic extractions. Now, at the risk of self-promotion, I give 4 to 5 of these courses in my office per year, but I don't care if you come to me. Go to somebody where you're allowed to work on live patients. I do a program on the road where we do this on models, and I bring high speeds and I show you how to section teeth, how deep to put the burr, what burr to use, how not to nick the adjacent tooth, how not to violate the buccal or lingual plates of bone. So, you don't want to do that because buccal and lingual bone don't grow back unless you have to graft them with a membrane. But you can take away interproximal bone in abundancy and it grows back. I teach you all that. But if you can find somewhere else that you can learn this live, that would be the first skill that you need to learn. Almost second or at the same time, you want to be skillful in site development. And what I mean by site development is, what are you going to do to the area where you just removed the tooth? Well, maybe if you're doing a denture on the patient, you're not going to put anything in the socket. You'll sew it up and have them bite on gauze, and a clot will start the process of angiogenesis for that patient. But in a lot of practices, especially today, the standard of care is socket grafting, socket preservation. There's 10 courses on this, and you need to know this information. Again, I teach that information as well, but it doesn't matter where you learn it as long as you learn it. So let me just slow down here. I told you, get your oral sedation permit. It's not really even a skill. There are certain things to go with oral sedation permits. Listen, I've never had one untoward incident in 22 years of providing oral sedation in my office. Not one. Not one where I had to call 911. Oh my God, I have a situation. So I have to believe that comes from 2 things. Good patient selection. I really don't think I work on ASA 3s very often or ever. So think about it for him. Why would you want to do that? Just let that patient go in a hospital setting. Why would you want to do that one patient? It's not even a hard thing for me to figure out. I work on ASA 1s, ASA 2s. I don't work on children. I'm talking about for sedation. And maybe that's part of it. I don't want to make it sound like having a permit doesn't come with requirements and responsibility. And yes, we thoroughly vet their medical history, and we thoroughly vet what other medications are on. I don't consider that a really hard thing to do. So secondly, so you have this oral sedation permit. Well, you're going to get teeth you have to pull, extract. So let's do it atraumatically. Secondly, how are we going to develop the site for further implant? And it's not just putting things in the socket, material in the socket. It also requires membrane sometimes and flaps and things. So yes, this requires a big commitment by you. And then lastly, and we'll obviously continue this at a later time, well, if you're going to do all that, why on earth would you not take the next and final step of the 4 skills and learn to place surgical implants. I mean, I got to tell you, for those of you that haven't done it, it is life-changing as a professional the first time you place an implant. I don't think it's unique to me. To place a titanium alloy abutment in bone and have it integrate and be able to put something on that abutment, on that implant, be it a tooth or be it an attachment to rescue this poor patient from wearing a full lower denture, it is life-changing, and it becomes amazingly an interesting practice. I just don't know how you can sustain yourself with basic crown and bridge the rest of your life. Of course, I guess maybe I'm being myopic, and there's those of you that just don't like the blood aspect of dentistry. But for those of you that would even give it a consideration, I will tell you, you'll never turn back. I don't know one person, personally, I don't know one dentist that's ever started this journey, even ones that weren't sure they wanted to do it, and went back the other way because it wasn't interesting enough. It wasn't rewarding enough. Yes, it is scary sometimes, and that's why you got to take baby steps in this journey that I've advocated for you. I told you in the last podcast that I'm going to end these with a little clinical tip, because I don't know whether, I did 2 podcasts ago, I did the whole one on clinical, and I can't tell whether that appeals to the broad masses that listen to me. Not that they're masses anyway. So here's my clinical tip, and this comes from one of my colleagues that actually wrote to me on this podcast, and he wanted to know about frenectomies. And the reason I talk so much about frenectomies is this. When you start extracting, when you edentulate a maxilla, and you finally start doing that on a regular basis, you're going to notice more than you did before that the frenulum can become an interference to your prostheses. Like, you might have not have noticed it prior to this. And so the first thing I would tell you to do is Google on YouTube frenectomies. It is a procedure that I believe you can really learn by reading articles, looking at YouTube, and maybe starting with a really easy one. And understand that there's 2 aspects when you talk frenectomy. There's a frenotomy, which is just the incision and relocation of the frenal attachment. So picture this in your head. So that would mean, imagine that you extracted teeth, you came back. I usually don't do these in the same visit that I'm extracting, by the way. I'm sure you could, but I don't. And you come back and wow, there's a strong frenulum attachment there. I didn't even see that. It becomes, I'm not kidding you, a 15-minute procedure to anesthetize them, pull on the maxillary lip, incising with a brand new 15C, and then sewing that up more apically, because as you incise it, it becomes a more apical, the flap goes apically, and then you don't sew it back over the frenulum area. Of course, you sew it a little bit apically to that, and you're done. There's a lot of approaches to this. What I just shared with you is basically a successful approach. I personally usually take where the frenulum was, even though I did a split thickness around it, right in the center where the frenulum was attached, I take that down to bone with a burr or with curettes. And of course, it's just like a socket. It granulates back in, it forms a blood clot, and I've sewed the apical area maybe 10 millimeters apically to where it was, with maybe 3 or 4 interrupted sutures. I could send you the full procedure if you want me to do that. And the only reason I'm bringing it up is because it becomes such a skill that goes along with full mouth extractions. We got a lot to talk about if you're into these discussions about why these skills, I mean, if for no other reason, this is Sunday that I'm speaking to you today. I'm going to go into my office this week, and I assure you that if nothing else, it's going to be interesting stuff. Think about it for a minute. I'm going to have 2, 3, or 4 hour appointments every day with 1 or 2 patients. And I'm going to be doing multiple extractions, site development, implant placement on patients I extracted 4 months ago. And along with that, I am a GP, so I'm also doing other GP skills. But it just makes the traffic less, and makes your day interesting. Gosh, I hope you're listening, and I hope one of you who has not been doing this will consider taking this leap of faith. I'm only giving you this from my heart because it's made for a very interesting career. I started all this surgical stuff probably midway through my career, so about 20 years ago, maybe a little bit earlier for me. And look, I am a giant advocate of you going real slow. So I'm not trying to get you to start doing sinus lifts and ramus grafts and all these other things, in the first 2 years of being, an implant surgeon. I think you also should understand that even though I present it as that any of us can do this, it does come with a responsibility of the type of patients you're working on. Understanding their medical histories, understanding what medications are on, understanding if they should be done with an oral surgeon or periodontist in a hospital setting. Hope this is helping you guys. Hope you have a great week ahead of you. Thanks for tuning in, and I'll see you next week on The Lionhearted.